So we're going to talk now about tracheal tube introducers, or Bougies, and specifically how they relate to pediatric airway management. First, we wanted to show you the equipment we have on hand in our ED, and then we'll get into uses and cases and some examples. But at point of comparison, this is the adult Bougie that we use routinely in adult intubation on the first attempt as part of our airway practice. Remember, this plastic single-use device is 70 centimeters long, it's 15 French diameter, and has a coude tip. It does able to flex it and hold its shape somewhat, but we keep it stored straight in the package and hand it to our operator that way.
And you can think, just because I was confused about what French means, you just divide by 3 to get millimeters. So 5 millimeters, so anything bigger than that should be able to fit a tube.
Mm-hmm. To go over the pediatric specific tube introducers, this is what we call our pediatric Bougie, and it's very similar in length to the adult version, but this is 10 French, and that would be 3.3 millimeters. It's more compliant than the adult version, has a coude tip, but again, in school age or older children, we've used this from time to time and had success.
That's for
what
size,
tubes? Yeah.
Size 4 tubes and bigger?
Up to 6.
Up to 6.
Yeah, 4 to 6 millimeter ET tubes.
And a 6.0 will fit through this will fit through a 6.0 tube. It's just a little tight. 6.5 and up, it's totally fine.
Good. And lastly, we just wanted to highlight, we carry a tracheal tube introducer or exchange device that we will use rarely as a neonatal Bougie, and that's shown here. So this is 5 French and doesn't have a coude tip. It's a much shorter device because the length of a neonatal airway is so short. Very flexible here, but again, it's orange colored to clearly differentiate it from the other ones. And this takes very small tubes, so 2.5 to 3.5 millimeter tubes can fit over this kind of adapted exchange catheter for neonates. Anything else to add about this?
You can put a little bend in it, but it's not as useful as the other ones, yeah.
Yeah, I would just say it doesn't have that coude tip, but the coude tip at this age group is really not helpful. The tracheal rings are not calcified, and so even if you had a coude, you wouldn't expect the traditional clicking feeling that you might, like that manual feedback that you would get in an older child or adult.
So for you guys, your everyday practice for routine intubation, I know what your answer is for adults. Bougie first every time. What is your answer in the pediatric, like the 4 to the 6.0? Are you using this every time as first introduction, or are you using stylet?
Anna?
So I trained at a place that did not use Bougie every time, and I think, but here at Hennepin, we tend to use Bougie every time. Part of the argument for using it every time is sort of this is the way that we teach our residents. This is how we set up. And I think there is benefit in saying this is how we do an airway every single time, and that increases success rate. And so though the studies don't necessarily say in all comers that it increases first pass success rate, it has been shown to be safe in the pediatric age group, and I do think that there's benefit in just that muscle memory of going through the same exact steps every time of an airway.
Yeah, so I would say I don't mandate it for the residents, oftentimes because peds airways are easier. They're more straightforward, sometimes the view's right there. That being said, there is some utility in doing it the same way every time and not having to vary based on the perceived difficulty of the case. But we have gotten some pushback from our pediatric colleagues historically that the Bougie is maybe dangerous or leads to pneumothoraces, other mucosal injuries, and that we should not use it unless we absolutely need to. So what do you guys think about
that? My feeling is that what we've done, I guess, a bigger picture view is tried our best to replicate the success we've had in adult emergency airway management for pediatric patients that are not neonates. And I think it's about the team aspect of it. It's having your respiratory therapist assistant and faculty physician being able to anticipate what's coming next. And so it's useful to, as we use the Bougie in all adults, to have the pediatric Bougie available for all cases. And we'd be remiss, I think, not to talk about laryngoscopy if we're talking about Bougies, but our system in adults, which is Macintosh-shaped video laryngoscopy on the first attempt, is also what I do in children. And because I'm using a Macintosh blade and pediatric jaws are pretty compliant, and getting a view is not often the difficult part. Placing the tube in with a stylet or a bougie, I kind of use it as a teaching exercise, and tailor it to the resident. But I think these are safe and effective.
And we did actually publish all the known instances of bougie use here at Hennepin in our modern era, and found it to be very safe, without any big differences between bougie use and styleted tube use. There was a couple kind of rare instances in each group which were not clearly attributable to either the bougie or the stylet. We'll post a link in the notes there. And there was recently a systematic review meta-analysis showing that bougies don't cause more trauma than tubes and stylet. That's in adults, but could that carry over? I think where we get a little more nervous is in those really tiny neonates. I don't know if you have anything more to say about that.
Yeah, I would say that there are some cases that are published in cases that were neonates where bougies were used where there was a pneumothorax at the end of the intubation. Whether it was causative, just correlative, we know that neonates are at risk for pneumothoraces after intubation because of just the positive, positive pressure given when you're bagging the kiddo. So I don't know that it's causative, but I am cautious personally with neonates, and I don't tend to use the bougie for neonatal airways. I do think if you are going to use one, I think just just recognize that it's a little baby and we should maybe be pretty gentle rather than just shoving it in there, to be quite honest. But I don't know that there's any proof that it causes any airway damage. My practice, I think I have no problems using the bougie, and I support using it in kids. For neonates, I think it's a tool that if we're having difficulty, we should know how to use and is generally safe, but I wouldn't tend to use it routinely for every neonatal intubation, my personal practice.
Yeah.
Yeah, I agree with that. You have it there for every case on hand as a rescue device, because I think that's definitely superior than attempting a neonatal surgical airway.
Yes.
But it's certainly an area where we don't have data, neonates or kids randomized data. And like adult studies that have never shown that the bougie is any worse than not using it, and it's safe, incorporating into our practice, for non-neonates has seemed like a good thing.
I think, we're a teaching facility, and so we have to recognize that we're teaching residents to be providers out in the community, and there are a lot of places that do not carry certainly neonatal bougies or even pediatric bougies. So I do think it's important that our residents know how to intubate with a stylet from an educational perspective. I also would encourage places to have a pediatric bougie on hand, but from an educational perspective, I think it's important that people know how to do it both ways. But here, I think it's reasonable in our standard practice to use it for most.
Yeah, you raise a good point. Matt published last year a survey of every emergency department in Minnesota, and pediatric airway equipment is something that was lacking from a lot of those. So we'll post a link to that too. And I think that is a good point. You should have that spectrum of skills, not that you have to use the bougie, that you don't know how to intubate without it. I think you should be able to do it both ways for sure.